Here we have the subcuticular or intradermal stitch. It is a buried dermal stitch used for excellent cosmetic results. We make the first pass through the epidermis 1 to 2 millimeters from the apex of the wound. We exit within the wound, and we leave the end of the thread without tying it down. Next, attach your needle to your needle holder. You want to place it at a slight angle, more than 90 degrees, to make it easier to go through the dermis. You can attach a clamp to the open thread to help it weigh down. You want to make a somewhat of an S shape along the wound, and we're going superficially through the dermis. We alternate the throws on the far side and then the near side. You want to make the entry of each throw either at the same level or slightly behind the level of the exit of the previous throw. Keep the throws consistent with both the level of the depth as well as the bite size. Make sure that the thread is not making any knots. Grasp the needle with the needle holder as soon as you make the throw to make it a faster stitch. Repeat this process until you get to the end. Maintain the needle in the dermal plane so that the suture tracks just under the epidermis. Tension should be low. Approximate without blanching the tissue. For the last throw, you go within the wound and exit out of the dermis. Leave enough room in the thread for tying. You can see that the wound has been closed and approximated well. And the suture is invisible. Now, to tie off the suture, we make a reef knot going once over the needle driver and grasping the same thread more distally and pulling it through, making a loop-like knot. You can make more than one knot, but since my thread is short, I'm only making one. Repeat the same process on the other side, going once over the needle driver and then grasping the distal end of the same thread and pulling it through. Cut the excess tails of the thread on each side. Next is the corner stitch or the V-stitch, which preserves the apex on angled wounds without creating dog ears. It's used for angular lacerations such as triangular wounds or corners of excisions. You enter on one side from the apex, from the epidermis, and then exit through within the wound. Next, on the V-flap, you want to enter within the wound through the subcutaneous tissue, bypassing both the epidermis and the dermis, and exiting on the other side of the wound, also through the subcutaneous tissue. Next, on the other side, you want to enter through the wound and exit through the epidermis. This is useful for approximating the wound and closing it without compromising the blood supply. Then you want to tie a knot with a surgeon's knot with 2 loops over the needle driver, and then 1 loop over the needle driver, making a reef's knot, and then another reef knot in the opposite direction. Bring all your instruments to one hand. And trim the tail. If you have a large corner stitch or V-stitch. You can also supplement it by adding regular simple interrupted stitches to help support the wound. Next, we have a pulley suture or a sliding horizontal mattress suture. It has a mechanical advantage for high tension wounds. Starting with making a normal mattress suture, entering 3 to 5 millimeters away from the edge of the wound, and exiting with equidistant on the opposite side, leaving a short tail. Then, moving distally or laterally to the first exit, we make a backhand suture going equal depth and exiting on the original side. However, here we want to leave a loop and not pull the thread all the way through. Then we take the needle and we pass it through the loop that we just formed. This creates a pulley-like system, helping in approximating large wounds. Then we tie off the wound in the normal fashion, with a surgeon's knot twice over the needle driver, followed by 2 reef knots. Pull all the instruments to one side and trim the tail. This type of suture usually uses a strong, non-absorbable monofilament like nylon or polypropylene. It's indicated for wounds under significant tension, like in the scalp, back, or joints, staged excision closures, where incremental approximation is needed. Next, we have the figure of 8 suture, which is a rapid technique to achieve focal compression and hemostasis. Pass the needle perpendicular to the wound about 4 to 6 millimeters from the bleeding point and exit on the opposite side. Then we re-enter from the original side, crossing over equidistant to the opposite side. This creates an X or figure of 8 pattern as you tie. Here I enter an exit within the wound. Then you tie the knot the same as usual, with a surgeon's knot, followed by 2 reef knots. This type of suture is used to control bleeding at small access points like femoral or venous sheaths, and for reinforcement of friable tissue, as well as temporary venous site closure. The material will depend on the depth. Non-absorbable monofilament can be used for skin or superficial vessel control, and absorbable can be used for deeper temporary closure as needed. The crossing strands compress the tissue and reduce bleeding. Master these steps of suturing first on simulation pads and low-tension clinical wounds. Match your suture choice to tissue and the goal: strength, time to absorption, and cosmesis, and always respect vascularity when tightening. These techniques, done well, prevent dehiscence, reduce infection risk, and optimize functional and cosmetic outcomes.